Thank you for joining me for the fourth in an 8-part series, The Essentials in Oral Health, exploring topics in preventive dentistry and periodontology. Sponsored by Johnson & Johnson, this series is offered exclusively to you as members of the Next DDS user community. I am Christine Hovliaras, your speaker for the evening, and it's my pleasure to be here with you. I've been a dental hygiene professional for over 30 years and president of Professional Savvy, LLC, an oral care professional marketing and continuing education company in New Jersey. My expertise includes dental clinical research, sales training, and a 3-year term as editor-in-chief of Access Magazine and editor emeritus of Access. I'm also adjunct faculty in the Department of Dental Hygiene at NYU University Department of Dental Hygiene. My presentation tonight is titled Managing Gingivitis Through a Brush-Floss-Rinse Regimen. And I'm excited to share this information with you. But first, a couple of housekeeping items. The webinar will run for approximately 45 minutes, and you can pose questions at any time during the presentation using the tool at the bottom of your screen. We'll collect your questions and address them as many as possible during and after the presentation. So without any further ado, let's get started. Tonight's learning objectives are the following: to understand the prevalence of gingivitis and its etiology, to review the deficiencies patients encounter when they're toothbrushing and flossing alone, and to also understand the oral health benefits of a brush-floss-rinse regimen and its effect on gingivitis. As we can see in this slide, gingivitis, as we know, is a disease of the soft tissues. We know this by what we see in the clinic and what I see in private practice as well. Tissues become inflamed, they're swollen, and they're sometimes bloody to the touch or during scaling or probing. This can be reversed through improved oral hygiene. And what we find is gingivitis is not periodontal because it does not cause attachment loss. And as we know, dental professionals play an essential role in maintaining the oral health and overall well-being of patients with gingivitis and healthy patients too. We also know that it's caused by the tissue response to plaque accumulation and associated biofilms that are present. It all starts with what we know as dental plaque biofilm, and many of you, now being in your school years for a couple of years now in dental school, you know that biofilms are a sticky microbial community found throughout the mouth. We find that there are over 700 species of microbial bacteria in the mouth and in the dental plaque biofilm. And what we find is that the dental plaque biofilm adheres to the tooth surface through attaching to the salivary pellicle and throughout most of the mouth. When biofilms form, we have planktonic bacteria. These are bacteria that are free-floating bacteria in the oral cavity. They adhere to a surface in an aqueous environment and begin to excrete and encase themselves in an extracellular polysaccharide matrix. What we also find is other planktonic bacteria attached to these bacteria anchored to the surface. And what we have is this continued adhesion of bacteria amongst each other that eventually leads to multi-layers of bacteria. And as many of you probably already know, the biofilm does form in about 5 different stages. So these bacteria will adhere to the other bacteria, and they become a complex structure. We have the inflammatory response that occurs. So we have dental plaque. When it composes together, it will result in a destructive inflammatory response. I don't know if you can see my pointer, but around the right central and lateral incisors, you're seeing quite a bit of gingivitis there. And we're seeing a little bit on the other left central incisor as well. And this is all caused from the dental plaque biofilm. Again, we need to intervene when this occurs, or else we'll have a much more serious complication with the gingival tissue. So let's take a look at the ADA classification for periodontal disease. There are actually, we're highlighting 4 types here. We'll also discuss the 5th type as well. But the case type 1 is gingivitis, and we know what gingivitis is. It's inflamed gum tissue. There is no attachment loss. There is bleeding upon maybe probing or scaling, and we also see pseudopockets. And there's no bone loss visually when we look at it radiographically, digitally. Class 2 is early periodontitis, and what we see here is definitely bleeding on probing that is present. We also see some pocket depth or attachment loss of 3 to 4 millimeters. We do see some localized bone recession, and we will see usually a grade 1 furcation involvement sometimes. Class 3, which is type 3, is moderate periodontitis. And what we find here is it's progressing more. We have pocket depths of 4 to 6 millimeters. We definitely have bleeding on probing. We sometimes have a grade 1 or 2 furcation involvement. And we also will have class 1 mobility. There will be definitely bone loss that's seen from a radiographic perspective, and also we may see some alveolar bone loss within a 4 to 6 millimeter depth from the CEJ. Class type 4 is severe periodontitis. This again, you will see bleeding on probing. Pocket depths you will see, and attachment loss greater than 6 millimeters. You will get a grade 2 or 3 furcation involvement, and that's where you're moving the tooth, forward and back, and with the class 3 you can depress the tooth as well. Again, that's with the class mobilities. And then you will see alveolar bone loss, 6 millimeters or more, and radiographic furcation involvement. Also, I want to mention with class type 5, this is in the case of refractory periodontitis and juvenile periodontitis. And refractory periodontitis, if you're not familiar with it, means that this is periodontitis that has been treated and has not responded to conventional therapy. I actually, when I was at my alma mater at Fairleigh Dickinson School of College of Dental Medicine, our school had closed in 1990, but I worked as a research hygienist in that school, and we actually did test refractory periodontitis patients there that we published research on, and we treated them with clindamycin. We had really good results with clindamycin with refractory periodontitis patients. They're also applicable to juvenile periodontitis patients. This is periodontitis patients who are younger patients who have a lot of bone loss around the molar areas, usually first molar involvement. So this gives you a perspective that when you're treating your patients in the clinic, you want to classify them according to this system so that you can accurately treatment plan them, determine what their dental and oral care needs are, and how to put together a treatment plan to treat their necessary oral care diseases. When we look at plaque control, what do we find is really the best thing to deal with plaque control? It's still mechanical removal with a toothbrush. That could be a manual or an electric toothbrush, as well as interdental devices such as floss, flossers, soft picks, toothpicks, and even a proxy brush. So that's really usually what we focus on as dental professionals, to try to treat the plaque biofilm. But is that enough? When we look at the next slide, is it really enough? Do we need to explore some other further adjuncts to help us as dental professionals to rid our patients of that biofilm? So let's take a look. I find this very interesting. Okay, I don't know if now that you're treating some of the patients in the clinic, like I said, I've been a hygienist 30 years, and I work in a prosthodontic practice 2 days a week in Morristown, New Jersey, and love what I do and treating, a geriatric population of people. But I do want to mention a couple of things. When we look at factors that affect our patients with oral hygiene care, we look at several different things. First, we look at how long do patients brush. And what we found here is that the most effective way at oral hygiene routine can be is critical to preventing plaque and gingivitis. And what we find is brushing and flossing alone, as performed by most of our patients, may not be enough to adequately control the biofilm. And some of the studies that have been published on toothbrushing frequency with patients show that 55% of patients who have been in this toothbrushing frequency study have claimed that they brush about twice daily. So that's 55% of patients across the board in the U.S. Secondly, we have 25% that have brushed once a day. So in my mind, as a dental hygienist and a practitioner, once a day doesn't cut it. It's not gonna remove the biofilm. It's not going to remove that. It's not going to do much to help that patient. And then we have 18%, which is our low end of people who brush 3 or 4 more times per day. And these are kind of our anal retentive patients who want a clean mouth, and they want to be no plaque in their mouth, and they want it to feel clean and fresh. Secondly, we find the average time that a patient brushes is usually between 24 and 60 seconds. Now think about that, okay? That's not a lot of time. You're not even 30 seconds you're brushing. Most people just brush so fast and don't pay attention to where they need to brush that there is such a need for our intervention. So that is another factor that we want to focus in on, because the American Dental Association reminds dental professionals to recommend that their patients brush at least 2 minutes of brushing each time they toothbrush. And then when we talk about flossing, another area that my patients need to do better on, and I'm always so diligent with instructing them, is that only 2 to 10% of patients floss regularly. And what I mean by that, or effectively, and most cannot or will not floss daily. And I was just in private practice on Monday. I'm going to be in private practice tomorrow. I would say that several of my 8 patients I treated on Monday, probably 3 of them were not, were flossing every day, and the other majority were flossing, sporadically. So that's another need that we really need, especially when you get out of dental school and you're in private practice. Your dental hygiene team and your, assistants working with you as well, they're crucial to having, implementing great oral hygiene care amongst your patients in order to improve oral health and the oral welfare, of the patient. Let's go to the next slide. What we find here, and I'm going to focus in on a little bit of what I do in my prosthodontic practice. I want to highlight a couple things. Poor technique is always a problem to plaque control, and you probably are seeing that in the clinic with some of the patients you're treating. Rarely practice, a lot of people don't do it consistently, and that's where I say it's so important to actually instruct your patients on how to floss and how to toothbrush so that they're effectively removing plaque biofilm along the gingival margin and on the tooth surfaces. I also want to say that with manual dexterity, it does decline with age, And I do want to mention a couple of statistics. The actual U.S. statistics by 2030, the senior citizen population, which is ages 65 and over, will triple-fold in the United States. From a global perspective, think about this, by 2040 it will quadruple globally. So what we're finding out, and you are seeing probably in clinic now, you have a lot of older patients that come into the clinic because it's less money for them to pay for their dental care. They have time on their hands because they're retired, and they like the interaction of being in the clinic and working with dental students. And I'm sure if you have hygiene students there in the clinic as well. And what we find here is that their manual dexterity will be decreased. And that's why compliance with instruction for flossing and brushing is so important. And you play a key role in doing that. Again, we want to make sure it's consistent with the patient and that you are adapting it to their needs. So you're offering them different options for what what you need them to do. Some other things we need to take a look at is when we look at the teeth, they're about 25% of the surfaces in the oral environment. The other 70% include the soft tissues, the tongue, the palate, you know, everywhere else in the mouth that bacteria can form. So it's so essential that we actually hit all those regions. And we know that the toothbrush and the floss, you know, go between the teeth and at the gingival margin. But for these other areas, we need to look at other applications to help us manage that plaque biofilm. So let's take a look at controlling biofilm through the oral environment. And this is where antimicrobial rinses represent a valuable part of your daily oral care regimen for a healthy mouth. And what we find is in healthy patients and in those with gingivitis, antimicrobial rinses represent a major control of bacteria throughout the mouth by preventing and delaying pathogenic organisms from colonizing into subgingival plaque. And this is highly important in order to keep your patients healthy. We know brushing and flossing mechanically remove the plaque biofilm, yet antimicrobial mouth rinses penetrate the biofilm to kill the germs that brushing and flossing will miss, okay, alone. So the next slide, we're going to take a look at 5 different categories of chemotherapeutic agents. I'm going to take each one separately, and if you have any questions, feel free to, you know, send myself and my team over at the next DDS your questions over so we can address them. The first is bisbiguanides, and this, as we know, is chlorhexidine. And most of us know what chlorhexidine is. It's a great product. I've used it with many of my patients over the last 30 years, thousands of patients I've treated. And chlorhexidine is a cationic, positively charged antimicrobial agent. It serves as an adjunct to oral hygiene care. It is effectively, it's able to effectively reduce plaque bacteria buildup and the resulting gingivitis. Note, however, that in the United States, chlorhexidine is a prescription mouth rinse product. So you must have a prescription to get the product and give the prescription to your patient. The reason for this is because long-term, the ingredients, long-term use of chlorhexidine will lead to the following kind of side effects, which you probably may be aware of with some of the patients you've recommended the product for to treat gingivitis. These include extrinsic tooth staining, taste perception alteration, also increased calculus formation. I've seen this a lot when I've prescribed it to patients when I worked in a periodontal practice. And then also, some people will experience a burning sensation. Sometimes there may be a little desquamation in some of the patients that you recommend it to, and there may be some mucosal irritation. But this is an effective product for reducing plaque and gingivitis. And it also costs a little bit more than an over-the-counter product. The next one is the phenolic compounds, and these are the fixed essential oils and also triclosan. So first we're going to discuss the essential oils, and these are a class of therapeutic agents that are used in mouth rinse formulations indicated for plaque and gingivitis reduction. And there are 4 different ingredients. I'm going to cover each one separately. The first is thymol. Thymol is derived from thyme oil, and it has significant antimicrobial activity. The second one is menthol. Menthol is derived from peppermint oil, and menthol provides that cool, like tingling sensation that you get, and it also provides antimicrobial activity. The third ingredient is methyl salicylate, and this is derived from wintergreen oil. Methyl salicylate adds both flavor and also antimicrobial activity to the formulation. And the last one is eucalyptol, and this is derived from eucalyptus oil. And this is a terpene ether, and it provides a cool, spicy taste within the mouth rinse formulation. What's interesting is the essential oils provide mechanism of action. The way that the essential oils work is actually it provides bacterial activity, and it works to involve altering the structure of the bacterial cell wall. It results in the leakage of those intercellular contents, that's that contents that the biofilm forms, and eventually will produce cell death, which is good news for us as dental professionals, because we need that additional benefit outside of toothbrushing and flossing. We also know that the essential oils also exhibit other activities that prevent plaque and gingivitis, such as altering bacterial enzyme activity. It will also extract bacterial endotoxins, the bad things in plaque that cause inflammation and the breakdown of the gingival tissue. It also will exhibit anti-inflammatory properties by inhibiting prostaglandin, and that's an enzyme that's involved in the formation of prostaglandins, which are primary inflammatory mediators that will add to that gingivitis. So it really does some great things, the essential oils, to provide a benefit to our patients. I'd like to highlight a couple of, let's see, what's our next one? Okay, here we go. A couple of points here. What we find is with the essential oils, it first provides 52% greater plaque reduction at 6 months when added to brushing and flossing. So that's highly significant. If we have our patients on the essential oil complex, such as Listerine, for 6 months, we should see a 50% decrease in plaque reduction. Secondly, we will see a 21% reduction in gingivitis compared to brushing and flossing. So that's highly significant. And in addition, we will also see up to 70% greater plaque reduction compared to brushing alone. So when you add the flossing to it, you do get a better, you do get more reduction in biofilm interproximally. However, you're still getting the great benefit of the essential oils with the 52% reduction in plaque and the 21% reduction in gingivitis, which is highly important to us as practitioners to help our patients improve their oral hygiene. The third component is the quaternary ammonium compounds, such as cetylpyridinium chloride and domophene bromide. When we talk about cetylpyridinium chloride, there are many. It is a cationic formulation. It is a therapeutic agent. It does alter surface tension and has a relatively high substantivity compared to the essential oil-based mouth rinses. What we find with CPC, it is bactericidal and bacteriostatic against both gram-positive, that's our early colonizer organisms, and gram-negative bacteria, and those are our later colonizer organisms in the plaque biofilm. We find, too, that it will help to rupture the cell membrane, which leads to a rapid leakage of the cell contents of the biofilm and eventually cell death to the biofilm as well. And more specifically, the CPC will increase bacterial cell wall permeability so that the agent can get into that biofilm quicker, because the cell wall is so more permeable. And it will also alter bacterial metabolism, inhibit cell growth, which is very important. We don't want, we want to slow down that biofilm from, developing further and then breaking off and going into another area of the mouth. And it will also reduce bacterial ability to attach to the tooth surfaces, which is really important as well. When we look at the next one, which is halogens, which we know as fluorides, we're going to highlight two of them, actually. Let me just go back. I went too fast. And those two are stannous fluoride, which is a fluoride component that does contain tin. And tin may enter the bacterial cell wall and impair its bacterial cell, I should say, and impair its metabolism. We also know that with stannous fluoride, it does lack stability when it's in storage, and it does have increased staining properties. So sometimes it can be a little questionable on its efficacy to reduce gingivitis, which is important for you to know. On the other hand, with sodium fluoride, we see a difference. We see some published research that shows that it does provide anti-plaque and also anti-gingivitis activity. And this is very important. So we have that. That can be also another agent that you can consider to recommend to your patients. And then the last group of agents is the oxygenating agents. And we know what these are. We refer to them as hydrogen peroxide and chlorine dioxide. As we know, hydrogen peroxide, its uses as a plaque and gingivitis agent. Well, actually, I should say its use is limited, as a plaque and gingivitis agent. It's really been shown to be effective in reducing tooth stain and also in whitening of the teeth when used twice daily. So I just want to make that clear. It's not to be used as a plaque and gingivitis agent, more as a reduction in stain and increasing whitening of the teeth. Chlorine dioxide, as we know, is highly used for basically controlling oral malodor. It is not used as an agent for plaque and gingivitis. There is no supported published research. Oh, we do have a question from the audience. The question is, how do you recommend approaching the plaque biofilm conversation with your patients? That's a great question. Thank you for whoever asked that. Thank you for asking that question. Great question. How I approach it when I'm in private practice is I talk about the oral systemic disease connection with my patients. That if you have inflammation in your mouth, that inflammation can be passed elsewhere in the body. So I focus with them on showing them in a hand mirror, with a hand mirror, where their gingivitis is after I do an intraoral examination, and I do an extraoral and I do an intraoral examination, check the tongue, then I do a probing of the tissue, and then I look at the tissue and look at that. And what I see, when I see the tissue is inflamed, I go right to the hand mirror, I give it to the patient, and I explain to them very nicely in a calm and communicative approach that, hey, I see a little bit of inflammation here. Let me show you where it is. I want you to be aware of it so that when you come back next time, after we're going to go over it now. I'm going to show you where it is. I'm going to show you how you're going to remove that, and I'm going to make a recommendation for other products that I can recommend to you, such as antimicrobial mouth rinses and antimicrobial toothpaste to remove the biofilm. And then when you come back in 3 or 6 months from now, we will be able to look back at that area to see if there's an improvement. So that's how I talk to them about it. And when I talk the oral systemic disease connection, I say that if you have inflammation in your mouth, that bacteria will go into the bloodstream and go to other areas of your body, can affect the cardiovascular system, the respiratory system. If you're a pregnant woman, you can have a preterm low birth weight baby. So that's really how I pose that question, how I explain that to them in a nice way and not a direct way, because we don't want to be too direct with them, because we want to have that collaboration with them and that respect so that they feel a confidence in us as their professional, and we feel that they're a team player working with us to improve their oral health. So I hope that answered your question. Okay, so on to the next slide. Okay, and I think we're doing okay on time right now, which is great. Okay, in summary, I just want to kind of conclude this section so it's very clear to everyone. There are 3 main antimicrobial agents in mouth rinses that are on the market today. The first are the fixed combination of the 4 essential oils that we just discussed here, and you have the combination that we utilize there. And this fixed combination of essential oils is found in over-the-counter products such as all the flavors of the Listerine antiseptic mouth rinses and other numerous private label brands. I just want to speak from my own professional point of view. I've been a hygienist for 30 years. I've been in private practice that long. I have, worked for a company previously and in my own company now, and still practice today. And over the thousands of patients I've treated, Listerine, and I've tested Listerine actually, believe it or not, as a research hygienist at FDU, and I find for me the Listerine essential oil complex has been a positive experience for the patients I've recommended it to in reducing plaque and gingivitis. And I love the fact that there are so many different line extensions of Listerine due to the fact that some people can't handle the alcohol or may have dry mouth, because of prescription medication. So the Listerine essential oils have been a real positive for me as well. The second ingredient is the quaternary ammonium compound, CPC. And CPC was first discussed in the scientific literature in 1939 and is included in many popular mouth rinse formulation concentrations today. The range is usually from 0.045 to 0.075. The actual minimum recognized therapeutic concentration is the 0.045. And we find that any cosmetic mouth rinses that are below the 0.045% combination may not provide the anti-plaque, anti-gingivitis benefits, just so that you know that, okay? So we definitely need to have the 0.045% level. The third ingredient, as we know, is chlorhexidine. We know that this is an effective antimicrobial agent and is found in prescription products in the United States, such as Periodontal and PerioGuard. We utilize it with our patients in our practice, but we utilize it for only a week and just to get them healthier, and then we'll give them a little bit of a break and they'll go back on it again, and that's because of the side effects with the staining and the calculus formation. So this gives you an overall idea of what you can choose from in order to look at options for your patients of what their needs are and what their oral care needs are and what they can tolerate to use intraorally. Okay, so the next one is, we know that anti-plaque and anti-gingivitis mouth rinses have shown the ability to decrease levels of mucosal and salivary bacteria, and their incremental effect on brushing and flossing alone has shown decreases in plaque and gingivitis of 51.9% and 21%, okay, when we were referring to the essential oil complex. And this provides an important role for daily oral care, okay, and they play a valuable role to help the patient when they may not be complying with their flossing and their toothbrushing. Another study that we just want to briefly highlight is after 6 months, the subjects in a brush floss essential oil rinse regimen, okay, had statistically and clinically significantly lower gingival index scores for gingivitis and plaque scores than did subjects in a brushing control group and a brushing and flossing control group. So with the additional benefit of that essential oil compound, we're getting a higher level in antimicrobial efficacy for both plaque and gingivitis. And basically, let me just hop back. I don't know if I jumped ahead here. Okay. And let's see. Let me just see if I... Okay, great. Okay, and what we're just saying is this long-term study, the use of these antimicrobial benefit mouth rinses will provide an additional benefit to the patients, okay, for their brushing and flossing regimen, and that's so important for us. Again, we know that what the percentages are. I also want to mention, too, that the importance of your professional recommendation to help your patients successfully manage biofilm is so highly important, as well as instructing them in proper flossing and toothbrushing instruction, and also, you know, in compliance with using the toothbrush twice a day to 3 times a day, and the floss at least once a day before they go to bed, before brushing. Whatever the flossing doesn't remove, it loosens, and the brushing will take away. And this just highlights the ADA recognizes the value of rinsing with an ADA-accepted antimicrobial mouth rinse to help reduce and prevent plaque and gingivitis. Okay, all right. Rosalie asks a question. We have a question from the audience. Can you talk about how you approach recalls and what you see in the patient's self-care? Okay. Well, Rosalie, some of my patients are on, some patients are on a 3-month recall, and they alternate between our prosthodontic office and a periodontal office. So they see us, you know, we see us 3 months, they go to the peri office 3 months. So we're seeing them every 6 months, but they're getting cleanings every 3 months. Then we have some patients who are 4 months, who have some basic gingivitis and bleeding, especially when I'm doing ultrasonic scaling and hand scaling, and there's a lot of bleeding you know, during that process, and there's a lot of inflammation. That's when I put them on more of a 4-month recall. I just want to make sure I'm answering your question. What do you see in your patient's self-care? For those patients' self-care, for those patients who are have the bleeding and upon the scaling and the ultrasonic scaling, hand scaling and ultrasonic scaling, I'm seeing these people are not flossing as much as they need to. They're not, you know, my recommendation for toothbrushing, you know, not that I want to bring toothbrushing into it, and using a toothpaste is I would, you know, recommend to them to use Colgate Total toothpaste. It's one of the best antimicrobial toothpastes on the market. And I'll have them also use the Listerine antiseptic mouth rinses as well. We usually recommend to some of our patients Listerine Zero because it's no alcohol, and some of the patients, as I mentioned before, will have they have dry mouth from their medications. So having that non-alcohol rinse with the essential oils provides that benefit and a nice, you know, comfortable rinse for them. So that's basically how their self-care is. The ones who are on 6-month recall are doing a really good job. They're flossing, hopefully not, my wish would be every day, but most of the time maybe they're flossing every other day. They are brushing at the gum line. I'm really kind of strict with them at brushing at a 45-degree angle, around most of the teeth, behind the anterior linguals of the mandible and of the maxilla, brushing on the linguals with the up and down motion with the head of the toothbrush. So important, so that the bristles of the toothbrush get into that gingival tissue versus, a side-by-side stroke that we would be using across the, buccal and the lingual surfaces of the posterior teeth. So hopefully that explains it to you. I find that stress plays a role in my patients' lives too. I find that when they're very stressed out, they don't comply with their oral hygiene care, especially the flossing. The flossing is out the window. I hate to say it. So I find that when they're less stressed and you've made an impact on them as a professional to give them a recommendation, to instill that it's so important to carry out that recommendation to, decrease that biofilm in their mouth and decrease that inflammation, will make a difference for them. So hopefully I answered your question, Rosalie. Thank you for asking that question. It was a great question. I just want to go to the next slide. Let's see here. Okay, I think this is one of our last slides, so I encourage all of you to ask a few questions now before we get to the end here. We're at the last one. Basically, I just want to highlight a few things. The biofilm, as we know, it's a complex structure. And, when we see plaque, we look at it and we don't think it's so complex. But when you read the literature on biofilm development, there are so many microorganisms that are in that dental plaque biofilm. And that little thing I scrape off from the gingival margin, there's hundreds of bacteria there. And they pose such a conquest for the gingival tissue. So it's so important that you encourage your patients to brush twice a day with a fluoridated toothpaste. Hopefully that's ADA approved. And that should be for 2 minutes. It's so important to do the 2-minute brushing time. And number 2 is to clean between the teeth with an interdental cleaning device. And again, my thing is you want to offer options to your patients. So my doctor, who I work with, is Dr. Mark Applebaum. He's a well-known prosthodontist in New Jersey, excellent practitioner. He is so big on the toothpick and taking that toothpick under the gingival margin. Especially many of our cases are we do highly big restorative cases, and we have a lot of patients with implants and a lot of patients with crown and bridge work, and we have implant supported dentures. So we deal with a high level of patient, a high level of treatment we've provided to these patients through a fixed, prosthetic implant, prosthesis, or a partial or full denture, or implants that we worked with the oral surgeon to actually, restore the crowns on. So it's so important to clean between the teeth, and whether it's the floss, the toothpick, the soft pick, the proxy brush, the floss threader, the super floss, it's so important that you encourage them to floss, and the importance of flossing for their own care. Number 3 is to keep a healthy diet. Okay, we all like to eat sweets, and I know around the holidays now, it's so important to eat a diet that's balanced with your nutrition groups, and avoiding those snacks in between, eating those 3 meals. Some people eat 5 meals a day. Visiting the dentist regularly and seeing the dental hygienist for a professional cleaning. Some dentists are doing their own cleanings as well. For an examination with the dentist, x-rays being done, and the professional cleaning. And then also, when you're recommending to your patients, definitely the use of an antimicrobial mouth rinse to reduce the bacterial count in the dental plaque. Also, making sure that you look at the research and the products that you're recommending to the patients, so that the research is valid and that the products you're recommending really will work for the patients. Okay, I think Sarah has a question. With all the research and studies out there, how do you decide what is evidence-based? Oh my God, this is right up my alley, Sarah. Well, I have a long research background over, oh my God, 20 years. I used to work for the Warner Lambert Company, I have to admit that. I actually helped them launch Coolnet Listerine Mouth Rinse back in the, oh my God, the 1990s. And when you look at research, this is what you have to do, and this is something I encourage all of you to do once you're in private practice with your teams, your dental teams or specialty teams, is you need to go to PubMed. Number one is you need to be a member of your professional association. That's number one. Number two is you need to read the journals that come from the professional associations that you're a member of. And that could be the Journal of the American Dental Association. You could be into research. It could be JADA, Journal of the American Dental Research Association. You could be part of the American Academy of Periodontology, reading the journal, their journal as well. So important to read the journals on what things are being published currently, and then also looking at the products that you're recommending and doing a search, Google search or Google Scholar search, to make sure that there are valid clinical studies that were done on those products. And when we look at a valid clinical study, we're looking at a study when you're approved, when the ADA approves a mouth rinse like Listerine for effectiveness in plaque and gingivitis, we're looking at a 6-month clinical trial, long-term trial. We're not looking at a 2-week gingivitis trial or a 3-month gingivitis trial. We're looking at a 6-month plaque gingivitis trial. And that's the kind of stuff you need to look at, is making sure that the research that's been published has a significant amount of patients in it to show a statistically significant difference versus a control group, and making sure that that sometimes the supervision of the rinsing is done under supervision at the clinical test site once daily, and then the patient would do the other rinse at home on their own. So it's all these things. It's making sure that there's published research in PubMed or Medline that show that the products that you're recommending are valid clinical products, that they justify the claims that they're making. So if they're making an oral malodor claim, there should have been an oral malodor trial done. If they're making a plaque gingivitis claim, there should have been at least 2 to 3 gingivitis trials done to show efficacy against a control group, or as well as some of the clinical trials will show a positive control group as well. Okay. All right, let's see. Okay. Okay, I hope I asked that. Okay, actually, Rich from my next DDS team brings up another point. Is everything supposed to be thoroughly studied? How do you differentiate between? Okay, so as far as differentiating, if a product's been thoroughly studied, going to PubMed and Medline to actually look at the research that's been conducted is highly important. And even going to the websites of the companies that manufacture the products, really you need to look at that to see what published studies they have for professionals on their website to show efficacy for their claims. So I hope that was helpful for you. And then let's see, the last slide is basically as dental professionals, we all should consider a brush, floss, rinse regimen with our patients when brushing and flossing are not enough to maintain gingival health. And that's so important. If you know your patients need a little extra boost to improve, to decrease that biofilm, to make their mouth healthier, to freshen their breath, then make that recommendation to them in order to get them to optimize their oral health for basically total health and wellness of them as an individual. So does anyone have any other questions? I think we have about, we're almost done. We're done, I think. I think we're all set, Rich. Is that correct? Thank you so much, everyone, for coming on tonight. I know it's the holiday weekend approaching here, so have a wonderful Thanksgiving, and thank you to Johnson & Johnson for sponsoring this series, and also to our team at the Next DDS. Have a great evening, and have a wonderful holiday. Take care. Bye-bye.